First of all, I want to thank everybody for coming tonight. This, to me, is, well, the whole meeting is incredibly important, but this, to me, is the absolute most important part of the meeting. It's bringing together physicians from a multitude of groups, multitude of disciplines, non-physician healthcare practitioners, patients, multiple stakeholders, all for a singular goal, which is to help patients. And for me, I think there's nothing more meaningful than that. So with having said that, we'll get started. You all have, oh my God, I sound like Catherine. You all have the agenda here. But tonight we're discussing a diagnostic or therapeutic conundrum. Really, it relates to the PCSK9 inhibitors' remarkable denial rate. And we have here representing a variety of groups, and I'm going to go through them so everybody knows who they are, because these are incredibly important people, and I feel so fortunate having everybody here. To my right, we have Dr. Peter Toth. Dr. Toth is representing the American Society for Preventive Cardiology. He's a board member. He's secretary of the organization, former president of the NLA, the current president of the American Board of Clinical Lipidology, and has published over 500 papers, a billion books, God knows what. Just gave a remarkable lecture on platelets that it was just phenomenal. Next to him we have, and he's an MD, PhD, and a family practitioner, and he'll share with us his experience as a family practitioner with regard to the PCSK9 inhibitors. To his right, we have Dr. Underberg. Dr. Underberg, also on the board of the ASPC, is an internist lipidologist. And the president-elect of the National Lipid Association. He has many publications to his name. He runs the Bellevue Hospital Lipid Clinic, and is the guy who I used to pick on when I was in 8th grade and he was in 7th grade. And there you go. And that was at Horseman School. It was the thing to do. Okay. To my left, we have Dr. Jellinger. Dr. Jellinger is, for those of you who don't know, he's a master of the American College of Endocrinology. There are 50 people who are masters of the American College of Endocrinology in the country, and he is one of them. He's the former president of ACE, which is the American Association of Clinical Endocrinologists, the former president of the American College of Endocrinology. He's a very smart and very nice guy, and he's representing the American Association of Clinical Endocrinology. To his left, we have Dr. Pamela Morris. Dr. Morris is representing the American College of Cardiology. She, too, has done many, come on, please. She runs the cardiovascular disease prevention program at the university. She is incredibly active in the American College of Cardiology, just wrote an expert opinion piece that is known around the world, probably. And is representing the American College of Cardiology, as I said. Next to her is Joyce Ross. Joyce Ross is a nurse practitioner and the president of the National Lipid Association. Probably the most interesting thing about Joyce is that she was, were you the first person to do apheresis in the country? Or First clinical case in the country.
1996 at Penn.
She was 12 years old. It was 1996 at Penn. And, but, I mean, she started the first apheresis program in the country. So that's remarkable. And next to her, we have Catherine Wildman, who is an incredibly remarkable, I'm using remarkable a lot, but Catherine is an incredibly remarkable person. She's a woman with familial hypercholesterolemia who, at a very young age, developed chest pain, was told, of course, it was psychological, and because women only have psychological chest pain, and ultimately, unfortunately, had an event and had to force her doctors to identify the disease FH. in her. She subsequently became so passionate about this, she started the FH Foundation 5 years ago, and the FH Foundation is now a world-recognized organization with multiple initiatives, including Cascade FH, the first and only registry for FH in the country. Find FH, which is a program that uses machine learning algorithms. You see Kelly back there, who's that giant brain next to the other giant brain. It was part of the FH Foundation, but he developed this. And has also been a part of 10 publications in major journals already on FH. So, I mean, it's an amazing group, and I'm very proud to be part of this. So now, let me go to my slides, having introduced everyone. Here we have PCSK9, Unraveling a Therapeutic Conundrum. And I have a few slides to show. The first is ASPC's mission, and tonight represents really, you'll see, a confirmation of what we have tried to do over the last 8 years. If you read our mission statement and then our vision, you'll understand what I'm saying. Our mission is to promote the prevention of cardiovascular disease, advocate for the preservation of cardiovascular health, disseminate high-quality, evidence-based information through the education of healthcare clinicians and their patients. And that is our mission statement. And here we have a wheel. And this is our vision, to interface with all other organizations involved with ASCVD treatments and prevention. And that is what we're doing tonight. And that includes patients, and that includes the organizations. And we consider ourselves really, in a sense, the center of the wheel, with spokes emanating outwardly, with bidirectional flow to all of these organizations. We are in a unique position where we can interact and bring groups together, and I'm very proud of that. So here we have these great groups. All right, so today's initiative, you know, the town hall meeting. This is the first of 2 town hall meetings. The first one will be to identify the issues and to discuss some potential solutions. We're going to have everybody speak about his or her particular interactions with this problem of PCSK9 inhibitor access. We'll get all the opinions of everybody. We'll have a second town hall meeting at the American Heart Meetings in November, and then we'll write a paper. And it'll be a joint paper, and we'll publish the paper, which will describe our findings and hopefully come up with some solid solutions. I've already told you we have multiple disciplines represented. All right, so just a few stats that are kind of terrifying. 80 to 90% of PCSK9 inhibitor prescriptions have been initially denied. That means your doctor writes a prescription for a PCSK9 inhibitor, and 80 to 90% of the time, the insurance company comes back and says, no, sorry, try again. And we try again. And the paperwork to do so can be burdensome, up to 17 pages long. Imagine what that does to somebody's office in terms of resources in the office, because our resources are limited, but we do it. And we try to get the prescriptions, we appeal the denials, and we try to get the prescriptions accepted. After these extensive appeals, about 27% of privately insured patients and nearly 50% of Medicare patients will actually get the drug. Again, quite a large number of people not getting the drug. Denials are capricious. They're absolutely capricious. Some insurance providers ask for ezetimibe first, others don't. Some require genetic testing for FH. Then they won't pay for the genetic testing for FH. Some require what's called the Simon-Broom criteria. Others don't. When they require the Simon-Broom criteria, they require a definite diagnosis of FH. That's a very hard thing to do sometimes. We know people have FH, and maybe they miss that by 1 point. They're not candidates for the drug in the eyes of some. Some require step therapy, also known as fail first. That means we have to try multiple medications before getting a person on the drug that we really want the person on. Trying multiple medications can take 6 months, and time is very valuable for people who are at very high risk. It has happened to me where I've prescribed one PCSK9 inhibitor, and the insurance companies come back and said, no, no, we don't cover that one. You have to prescribe the other PCSK9 inhibitor. So I prescribe the other PCSK9 inhibitor. They say, no, no, sorry, we deny it. So it's like, okay, why did you have me prescribe that then? So then we go through the whole second appeal or third appeal. Second appeal is in North Carolina. Blue Cross Blue Shield now charge physicians $250. So if a doctor wants to put in a second appeal for a patient for Blue Cross Blue Shield in North Carolina, they have to pay $250. Now, they will get the money back if they win, but they won't get it back if they lose. So that is quite an interesting situation. Patients are, in some, being denied a revolutionary advance, what I frankly consider to be the most revolutionary advance in lipid management in 30 years. And for these people, these are all high-risk patients. I mean, the drug is indicated for high-risk patients. We're not talking about run-of-the-mill patients. Time is plaque. So the solution, which apparently is so tiny that I can't read it, we will discuss what the solution will be. So these are just some concepts. Obviously, we'll all get together, talk about this, hear your voices. But one of the solutions is maybe we should let doctors do what they're supposed to do, like prescribe on label. There's a PI for every drug. Doctors can prescribe according to the PI. Well, maybe that's, you know, an appropriate thing to do. And I'm just going to read this to you so you know what's in the PI. So what is the indication for PCSK9 inhibitor? PCSK9 inhibitor, this is taken directly from the PI, is an antibody indicated as an adjunct to diet and maximally tolerated statin therapy for the treatment of adults with heterozygous familial hypercholesterolemia or clinical ASCVD who require additional lowering of LDL cholesterol on maximally tolerated statin therapy. That is not very complex in my mind, okay? And yet we cannot prescribe according to the label. We need to honor the patient-doctor relationship. So we have to go back to that because that has been deeply damaged. We need to move away from certain value calculations. You know, there are a lot of reports that have come out that have valued lives of patients and done these calculations, these pharmacoeconomic calculations, trying to assess whether or not it's cost-effective to use these medicines. And in fact, one of these value calculations or one of these assessments was just published in JAMA, the Journal of the American Medical Association. The first author was Kazi. And in that, there were several flaws. I'll just name a couple of them. One of them, which ICER also used, ICER was invited to this meeting. I got a very nice response from them. I want you to know that they were busy, but they will speak to us. So they use something called QALYs, or quality of adjusted life years. QALYs are so bad as a metric that, that England is deciding now to move away from them, and that the Affordable Care Act prohibits their use in policy decisions. And yet, in every decision, in every pharmacoeconomic evaluation of the PCSK9 inhibitors that we see now, QALYs are used. They ignore future life issues. They ignore familial issues. They ignore the toll that Catherine's family took, you know, when she had her event. I mean, all these things add up, you know, and not to make you feel terrible, but when children see their parents going through these things, and the children are young, it has an impact on them. And I can tell you, I will tell you, I personally went through something, and it clearly affected my children. So, you know, none of this is considered in the pharmacoeconomic evaluations. Tom Frieden, the director of the CDC, said very intelligently, I think, in 2013, that even one preventable death is one too many. Okay, even one preventable death is one too many. Yet in the Kazi paper, they acknowledge that 4.6 million heart attack, strokes, or death could be averted by the PCSK9 inhibitors, but they're not cost effective because they'd have to be priced lower. So what happened to that one avoidable death? That's really one of the issues that I have here. Finally on this, and then I'll move forward. I know I'm talking a lot and I apologize, but it's a burning issue. ICER actually predicted that the PCSK9 inhibitors in their first year would cost $7.2 billion. That's how much they'd cost the system. They were off by a little bit. It's cost about $80 million. So they got, it was 1.2% of what they predicted. A subtle miscalculation. The problem with that is it affected the insurers or the PBMs, pharmacy benefit managers, who looked at this and said, oh my God, we're going to get slaughtered, made it so difficult that doctors didn't prescribe or doctors were denied. So they, in a sense, created the problem through fear. Okay, so just a couple slides left. This is showing, this is from the FH Foundation, and we have these data from Cascade FH, and you can just see, remember, one of the groups for PCSK9 inhibitors are the FH patients, and this is what they look like, and this is only a portion of the data. We have about 4 times these data at this point, but the untreated LDL cholesterol is 239 and a treated LDL 134. That leaves a big gap to where we want these patients to be, because the lower the LDL cholesterol, the less likely these patients will have heart attack, stroke, and die. We don't want to leave them with an LDL of 134. There's an unmet need here, and these people, the FH patients, I will tell you, are being more deprived of the drug than anybody else, in my experience. All right, this is one case I'm going to present, and then I'll hand over the mic. This is a real case. Okay, this is a 40-year-old gentleman with familial hypercholesterolemia. He had his first infarct at age 17. He had a bypass. He had multiple stents. He had graft disease, more stents. Was on apheresis, changed insurance. Insurance then wouldn't pay for apheresis. Okay? LDL is 340 on high-dose statin and ezetimibe. So now apheresis is not being covered, so try a PCSK9 inhibitor. PCSK9 inhibitors denied. I go through second appeal, peer-to-peer conversation, have a very nice conversation with a cardiologist. I made a fatal flaw in that conversation. Typically, I ask the name of the doctor, but this conversation was going so well that I thought, you know, this is an easy one. And got off the phone and said, yeah, it's going to happen. And next day got a denial. Denied the PCSK9 inhibitor. LDL 340, young guy, heart attacks, closing grafts, multiple stents. You cannot tell me that his life is not being threatened by being deprived an agent that can dramatically lower his LDL cholesterol. Okay? So I will end on that note and move along next. Peter.
I couldn't agree more with absolutely everything that Seth said, but I'm going to add some other thoughts here. We are living in a time where we have many more millions of people insured under the Affordable Care Act. All my patients are experiencing profound escalations in their premium costs as well as their deductible costs. My patients are being denied not just PCSK9s, but routine lab testing. We have to go through appeal after appeal for a CT. And my question to the PMBs and the executives at the managed care companies is, what the hell are you doing with all this money? This is collusion. These people made an active decision 2 or 3 years ago and went to the press with it and said, we're going to build a wall against paying for PCSK9s. And they've held to it. Now, collusion's illegal. Why is it that if they're saving the healthcare system so much money, premiums go up, they pay us less and less? In fact, they don't pay us for a lot of what we do. And if we want to be paid, we have to get on the phone and harass them. Why is it that the suits are making multi-million-dollar bonuses and carrying this stuff home in wheelbarrows to the bank. It is unconscionable. And everybody in this room knows that it's true. Why are these companies making record profits? Because they say no to life-saving drugs like PCSK9s. And I really think that if after the outcomes trials come out, if this pattern of collusion and denial continues, then I think we really need to make a push for Congress to step in and ask some very serious questions. Now, I have some examples of my own. So, I've got a 62-year-old disabled gentleman. He's got 32 stents. 32 stents. Totally statin intolerant. Can't tolerate Zetia. And his LDL is 287. And this guy's income is about $800 a month. So after multiple appeals, we got one of the PCSK9s approved for him, but at his cost of $600 a month. Now, what kind of a bad joke is this? Do you think they didn't know what they were doing? This is my only shot at helping this guy. And then, of course, this one's actually pretty humorous. So we went through appeal after appeal, jumping through hoops, asking for a specific PCSK9. And after I don't know how many attempts, they said, well, we don't cover that drug. And so after 3 other phone calls, we found out they covered the other drug. But do you think they told us this? They just make it as difficult as possible every step of the way. And they conjure up every conceivable excuse. Now, I think everybody in this room knows that this has become something of a ridiculous situation where they have rendered us powerless. But I think we need to rally around this and try to develop some unity and a plan. And if really after the outcomes trials come out, this same pattern continues, I don't think we have any choice but to try to take this to Congress. I am confident at least some people will listen, and we might be able to get some hearings going and hold some feet to the fire and hold some of these people accountable, because to me it is immoral and unethical that all these companies say no, and yet they're bringing in extraordinary, ridiculous amounts of money. Everyone's paying more, they're getting less. What are they doing with the money? Am I wrong? 2 other games. Seth already mentioned that they demand that you try Zetia. Gee, you know, for years, Zetia was refused and it was the pariah of lipid-lowering medications. Now all of a sudden you have to try people on Zetia. Now I love Zetia, I've always used it, but come on, it's just another gimmick, because obviously if you have a patient with an LDL of 287 who's statin intolerant, we know that Zetia, scientifically, we know that it drops LDL about 20–22%. Is that really going to get a patient with 32 stents down to goal? No. So why wait? Why delay? Now, I'm all for using Zetia and a PCSK9, but don't tell me I have to try Zetia first to see if the patient with a 287 gets to goal. And then I think the other one that I really have come to really despise, and which really sends me into orbit farther than it sends Jamie, is when you've tried someone on 4 or 5 statins and they say, well, you haven't tried them all. Really? Anyway, you catch my drift. All of you can relate. It has gotten ludicrous. We've lost control, and we have to find a way to get it back.
Thank you. Well, thank you. This is clearly a very impassioned subject, and we want to hear you know, everybody's comments, and you can see all of us we're going to be going on for a while about this, I think. Dr. Underberg.
So, how many people remember those Saturday Night Live skits that used to begin with lowered expectations? So what I'm going to talk about actually is what I term unintended consequences that have forced, I think, lower expectations, specifically around care providers and their interactions with patients. And I want to focus actually a little bit on how all of this does impact providers and their relationship with patients. So I'm going to kind of go through 3 points and then talk about what I think their consequences are. The first is that I think many of these decision algorithms that we've been talking about already are not consistent with usual care or best practices. So I'll give you an example. It's a real case. A patient of mine who has heterozygous familial hypercholesterolemia, whose LDL cholesterol off medication was 300. On 40 milligrams of rosuvastatin, the most potent statin, the LDL cholesterol went down as expected, around 50%, with an LDL cholesterol of 150. Lp(a) was elevated, and the patient had increased carotid intimal medial thickness. I don't think anyone in this room would deny this was a high-risk patient with familial hypercholesterolemia. The algorithm to move forward with PCSK9 approval for this particular patient required that the patient fail 2 statins. And according to the payer, he had not failed 2 statins. Now, the patient had not failed 1 statin. The patient had responded appropriately to the most potent statin. So, in my next section, I'll get to the consequences of that. Number 2, many of these algorithms and systematic approaches to coverage may indeed encourage care that could be harmful to a patient. If you have a patient who has had serious side effects to statins, yet payers require that they show that they are on some sort of a statin, you are now, in many cases, faced with placing someone on a statin who should not be on a statin. And that does come up. And there is pressure to do that when it is not the appropriate care for that particular patient. And then finally, as Peter mentioned, we run into situations where there can be delay of care based on algorithms. So what happens because of these? Well, the first is that in the first example I gave you with my patient who needed to, quote, fail 2 statins, only 3 things can occur, right? The patient can be forced to take a less potent statin, right, or told to take a less potent statin. Is that quality of care? No. I actually think that's malpractice, to take an FH patient who's on the most potent statin and then put them on a less potent statin. So what is the alternative? Well, the provider can give the patient a prescription for a less potent statin and tell them not to take it. Well, that's essentially unethical behavior on the part of the physician. So we've now got an algorithm of care that is forcing a physician between 2 choices, malpractice versus unethical behavior, when all of us have taken an oath to care for our patients. The next case scenario, the person who's forced to be on some dose of a statin, even though they've had significant side effects on that statin. So now the patient is offered a medication in a class that they've had problems with. The patient is now faced with the decision to either do this or not do it. And now the guilt is transferred to the patient. Do I do something that I don't want to do that may actually harm me? Do I pretend to do it and not tell the truth? Now we're encouraging unethical behavior on the part of our patients. There can't be anything good about that. And then finally, what Peter alluded to was the delay of care. That often now we're being asked to use medications that we were formerly denied, bile acid sequestrants and ezetimibe, before we can use PCSK9 inhibitors, when we know that in many cases these medications will not get our patients to the goal they need and will only further delay the time during which they need to achieve the required LDL cholesterol reductions. I'm not going to stand up here and discuss the importance of LDL lowering in patients who have inherited lipid disorders, but the longer you wait, the worse it is. And so, again, when we think about how all of this impacts the provider is now faced with a series of unwinnable situations. The patient is faced with a series of unwinnable situations. I'm not a psychiatrist, but when patients often present with depression and anxiety, it's often because of decision loops where they feel there is no exit. The person who's in a job they can't get out of, the person who's in a relationship they feel they can't get out of. And now we are forcing a series of situations on our providers and our patients that lead to a variety of emotional and other issues that can't be healthy for anyone's care. And so again, when we think about this in terms of a variety of different aspects, I think it's key to also think about emotional issues, stress and anxiety, ethics and quality of care that come into play, and the expectations that we have for ourselves and for our patients, and how we can let people put us in this position. And it should not and it cannot happen. And that's what I have to say.
Thank you. By the way, when we're all done speaking, we'd like well, not everybody, but some of you to get up and tell us your stories and your opinions as well. So I just want you to know that will come. We are noticing a commonality here, which is that physicians are losing control. So the power now is with the patient, and that should be a common theme. Patients have the power to make the difference, and they have to become their own advocates and work with the physicians. And we need to re-strengthen the once sacrosanct, can't speak anymore, it's a little late, sacrosanct patient-physician relationship. Dr. Jellinger.
Well, thank you for inviting me. I'm the token endocrinologist. There's a couple of others, I guess, in the audience, and it's a pleasure to be here and share the endocrinologist perspective. And I echo very much the passionate comments by the three speakers here. There's nothing more to say. They've said it so beautifully, and it's so true. We have lost control. The obvious intention is to wear us down. I can win those battles if I get on the phone and very vociferously scream and yell and insist on talking to someone higher up, et cetera, and question whether they are in fact a peer in a peer-to-peer discussion. They often are retired pediatricians or whatever. But I can't do that every day, and I can't do that more than once every few days because I'll go home and have my own myocardial infarction, I think. So it's a pleasure to be here. I'm going to switch gears. All the passion has come out here because this is a group of cardiologists. And endocrinologists spend so much of their life dwelling in the realm of diabetes. I wanted to give you some background in terms of how we view the highest risk patients. I believe endocrinologists in most instances are really treating the highest risk patient, the diabetic patient. And just to give you background, I don't know how much any of you know about diabetes and the CVD impact, and as a result of that, why endocrinologists are so interested in agents like PCSK9 inhibitors that can lower LDL to new depths. I'd like to just give you a little bit of background. In case you're not aware of the fact, there's this incredible epidemic that we're going through, and here's 1994. You've probably seen versions of this. In 1994, there was an incidence of diabetes greater than 6% shown in that whatever color, yellow color, the darker yellow color, and as we go up the ladder, 2000, more yellow and some red comes in. And then in 2011, wow, what happened there? Most of the country is at a pretty high rate of diabetes. And in 2014, it's off the charts. So make no mistake, there is an epidemic of diabetes. It's in front of us. It's raging, and we see it every day, especially if you consider prediabetes and metabolic syndrome as sharing many of the risks. So this epidemic is here. And if you looked at the obesity maps, they parallel this almost perfectly. So it's really an interesting story to see how obesity and diabetes go hand in hand. But to make it clear, obesity is not required for the development of type 2 diabetes. It just augments the appearance of it. So we know it's an epidemic. Here's some data. In 2012, which is actually the last year we have data from the CDC, 29.9 million Americans, that is 9.3% of the population in this country had diabetes. That's almost 10%, it's huge. When I started in this field, too many years ago, it was like 4 or 5%, 6%. New cases of 1.4 million Americans are diagnosed every year, and this is 4 years old, it's probably greater now, every year with diabetes, and undiagnosed. Of the 29.1 million, 21 million were diagnosed and 8 million were undiagnosed. Now, we're doing much better at diagnosing diabetes. At one time, that undiagnosed number was much closer to the diagnosed number, but there's a huge number of patients who have undiagnosed diabetes that we see in our office every day. And then there's a subject, the area of prediabetes. In 2012, get this number, 86 million Americans aged 20 and older had prediabetes. So, it doesn't sound like a very worrisome situation, prediabetes, it is. The pre-diabetic patient shares a significant increase in cardiovascular risk and some increase in microvascular disease, but largely in cardiovascular risk. It begins way before the diagnosis of diabetes is made. According to ACE, the organization I represent, the LDL and blood pressure goals for patients with prediabetes are the same as for diabetes. We don't look at it any different. You can argue about whether their blood sugar should be treated, and some yes, some no. But LDL and blood pressure goals in patients with prediabetes should be the same as those with diabetes. Not to mention metabolic syndrome. We've all heard about this. I don't know how much you think about it. 35% of all U.S. adults and 50% of those over 60 in 2011 and 2012 were estimated to have the metabolic syndrome. Now, that's also better termed the insulin-resistant syndrome because that's really what's at the heart of metabolic syndrome. Now, that's 50%. Now, patients, we all know, with insulin resistance or metabolic syndrome are also at risk for increased cardiovascular events and early cardiovascular demise. And they slip through the cracks because they don't have terribly abnormal values. Their triglycerides are a little bit high, their HDL is a little bit low, their LDL may be slightly high, their blood sugar may or may not be abnormal, and their blood pressure is marginal, but they have that cluster of abnormalities known as insulin-resistant syndrome and metabolic syndrome, all adds up to increased cardiovascular risk. They are what makes prediabetes happen and also is present in about 80% of people with diabetes, insulin resistance. So there's a huge number of people out there at cardiovascular risk, whether they have overt hyperglycemia, meaning diabetes, or whether they have prediabetes or metabolic syndrome. The cardiovascular risk in diabetes. Heart attack and cardiovascular death rate in persons with diabetes is 1.7 to 2-fold greater than the non-diabetic population. Tremendous risk, tremendous increased risk. I think you all know that about 70% of individuals with diabetes will die from a macrovascular event, either a stroke, a heart attack, or some complication of a vascular occlusion in the lower extremity, etc. 60 to 7%. When you look at a diabetic patient, you're looking at a macrovascular event in front of you at a very high risk. So that's the background. We have a study that told us about the cardiovascular risk in diabetes, a very important study which has since been neutralized a little bit by the comment on the bottom. Well, what this famous study by Steve Hafner showed, if you look in the two middle bars, the non-diabetics who had a prior heart attack or myocardial infarction were at the same risk as a diabetic patient who never had a heart attack. So by looking at a diabetic patient who never had coronary artery disease, or at least diagnosed coronary artery disease, they are at the same risk as non-diabetics who have had a myocardial infarction. And I think this group knows better than any that patients who have had a myocardial infarction, non-diabetic, are extremely high risk for yet another. So right away, from this study, diabetes became a cardiovascular disease risk equivalent. Just by having diabetes, it was like you had a heart attack. You're at the same risk. Now that concept was carried forward for quite a number of years. In subsequent studies, as this text below says, more recent studies suggest that this is probably mostly true in patients with long-standing diabetes, that there have been many studies in patients with diabetes for less than 10 years that don't show it's a cardiovascular risk equivalent to the extent this does. But whether you buy that just looking at a diabetic is a cardiovascular risk equivalent or not, look at the second bar and the fourth bar. These two bars are the ones not talked about from Hafner's study. Look at the diabetic patient, the diabetic patient who had a prior MI versus a non-diabetic patient who has a prior MI. A huge difference between 18.8 and 45% 7-year incidence of another MI. So the patients who have diabetes have this, and have had an MI, have this incredible increased risk for a second MI. That fourth bar on the right is something that has been overlooked a little bit in this famous study because of this interest in the second and third bar showing that diabetes is a cardiovascular risk equivalent. And it may be in some patients, and it may not be in all patients, but surely a diabetic who's had a heart attack is at huge increased risk for another heart attack. It's higher than anybody else. We talk about the Improve It study because the Improve It study is what really, I think, has opened the door for the utility of PCSK9 and combination therapy. Because the Improve It study drove LDL down to about 52, and showed an incremental benefit when ezetimibe was added to statins, and was strong evidence for the lower is better. For the LDL theory, not even a theory anymore, lower is better, has been strongly supported by the results of the Improve It study. When LDLs were brought down to 52, we got further benefit. Very nice study, nicely done. Wasn't an overwhelming benefit, but it was a statistically significant benefit. But look what I put in red over there. Almost the entire benefit in the Improve It study was seen in diabetic patients. If you take the diabetic patients, of which 27% of the cohort had diabetes, not 80%, 27%, yet they drove this significant finding quite extensively. Look at the difference between no diabetes and diabetes. You take the diabetic patient out, I don't believe you even reach a statistically significant benefit with ezetimibe plus simvastatin. Clear proof that diabetic patients really do benefit from lowering LDL to at least 52 on average, as in the Improve It study. The 4S study years ago showed a similar robust benefit in diabetic patients as well. So the Improve It study opened the door for lower is better and the importance of doing this in diabetic patients. And then we have the cholesterol treatment trialist collaboration, the CTT 2010, which really nailed it. You know, that's 174,000 patients, 27 studies and a meta-analysis now. We all recognize the inherent weaknesses in meta-analysis, and they're not the highest form of evidence, but when they're this large and the data comes out this strongly, it actually does have value. So what we're seeing here, that even in patients, when these 27 trials were meta-analyzed, even in patients whose baseline LDL was less than 77. For each 39 milligram per deciliter reduction in LDL, there was a 29% further reduction in major vascular events. And for those patients whose baseline LDL in the meta-analysis was less than 70, a 39 milligram per deciliter further reduction in LDL led to 37% further reduction in major vascular events. There seems to be no bottom to this. Now understand, the CTT is not an intervention trial. It's just looking at patients who had LDLs less than 77 and who had LDLs less than 70, comparing them to those that had higher LDLs, and saying when you had an LDL less than 77, you did 29% better than if you had a higher one, et cetera, et cetera. But this clearly shows that even at baseline LDLs that were considered low by everyone, further lowering makes a difference. So I wanted to give you that background, and that, of course, included many diabetic patients. Give you that background in terms of what diabetes is all about and why most, but not all, endocrinologists have a serious interest in treating complex lipidemias and treating the diabetic patient, not only for their blood glucose lowering potential, but also, obviously, for the comorbidities of hypertension and hyperlipidemia. And what I heard here from the gentleman before me was so reminiscent of what we live in diabetes. We have some wonderful new diabetes medications, very free of many side effects. and we have to treat the failure before we can get to the next stage. And you lose all that time, and it's really a horrible situation. We're on the phone on my right hand with the insurance companies trying to plead for our diabetic medication, and on the left hand for our aggressive cholesterol-lowering medication. So it's a busy day in our offices. So with that, I just wanted to share with you our interest, our perspective. ACE as an organization has a strong belief in the lower is better in terms of LDL. We do recommend to our members that we use targets and goals. The new version of the ACE lipid guidelines, the 2017 version of the ACE lipid guidelines, is nearing completion. I'm privileged to chair that. And I think when it comes out, it will provide a lot of clinical judgment for patients, for physicians, whether they're treating patients with diabetes or not. So thank you for your time. I appreciate it.
Well, thank you very much, Dr. Jellinger. I think I would just add one statement to that, which is I think Dr. Jellinger just proved that diabetics should be in the PI and are not in the PI for PCSK9 inhibitors. So you guys have even greater trouble than we have. So, yeah.
Well, thank you very much. I was asked to, I'm chair of the American College of Cardiology's Prevention Section and Prevention Council, and I was asked to present the American College of Cardiology's perspective, not specifically only on PCSK9 inhibitors, but on the role of non-statin therapies in managing high-risk patients. So as we all know from the ACC-AHA guidelines from 2013, it was recognized by the authors that there are patients who have a less than anticipated response to statins. They're unable to tolerate a less than recommended intensity of a statin, or they may be completely statin intolerant. At the time of the publication of the ACC-AHA guideline, they did state that you should give preference to drugs that actually have been shown in randomized controlled trials to have ASCVD risk reduction benefit. And of course, as we all know, at that time, there weren't any clinical trials that showed benefit of non-statin therapies. So in 2013, the American College of Cardiology launched a program called the LDL Address the Risk program. This was a multi-stakeholder and quality initiative, which was really designed to improve patient outcomes by driving awareness of what were the gaps in the management of dyslipidemia. The very first think tank was held in 2013, and the outcome from that, looking at the needs at the time, and I should mention this think tank was held before the release of the 2013 guideline. The main results of that were, one, a publication, which was a review of all the different guidelines which were currently available and comparisons, and most importantly was the ACC Statin Intolerance app, which allowed, and I think is very, very useful in this environment where we're trying to justify PCSK9 inhibitors. This algorithm, this app provides a systematic, rigorous approach to the diagnosis, evaluation, and management of statin intolerance. But the second think tank was held in September of last year. Again, a variety of stakeholders, but at this particular meeting, there were both patient advocacy groups, there were health plans, pharmacy benefit managers, drug manufacturers, and health systems. And what was identified at this think tank as a critical need was that there was a need for expert consensus guidance on how to incorporate non-statin therapies into treatment strategies for these high-risk patients. So at this time, if you remember correctly, the PCSK9 inhibitors had just been approved the summer before. This was held in September. But there was a lot of confusion among payers as well as among clinicians about how to use these drugs and how to reimburse these drugs. So the result of this think tank was then the 2016 ACC Expert Consensus Decision Pathway on the role of non-statin therapies for LDL lowering in the management of ASCVD risk. Don Lloyd-Jones was the chair of this writing group, and I had the privilege of being his vice chair. So the purpose of the ACC decision pathways are to provide specific guidance when there is less than adequate randomized controlled trial evidence to guide guidelines. At this particular one, we had new evidence from the Improve It trial as well as from HPS2 Thrive. This is since the publication of the 2013 guidelines and also the publication of 2 of the PCSK9 inhibitors. The questions that were considered in this document were: in what patient population should non-statin therapies be considered? In what situation should they be considered? When is the LDL not low enough? When has there not been enough lowering? And how should you handle statin intolerant patients? And if non-statin therapies are to be used, in what order should you use them? Which agents and in what orders? We did reintroduce some what we called thresholds for consideration of net benefit. Rather than using the concept of LDL goals, indicating that at a specific level of LDL cholesterol you should add a non-statin therapy. Rather, what we looked at is when should you consider whether or not there would be net benefit? When would the potential harms from the drug be outweighed by the potential benefit? So we looked at both the percent LDL reduction based on whether it was high or moderate intensity statin therapy, and then also introduced absolute levels of LDL cholesterol or non-HDL cholesterol levels in diabetics. Again, these were not considered firm triggers that you should add a non-statin therapy. Rather, this is where you could consider the addition of non-statin therapy. The agents that were considered, you can see here for the purposes tonight, we'll focus on ezetimibe and the PCSK9 inhibitors. Again, we started with the 4 ACC-AHA statin benefit groups, which you all know by heart here. Then we came up with algorithms for care. I'm just going to briefly walk you through one. The green is which patient group was being addressed. The blue boxes are what are the thresholds for considering action. The purple boxes are the clinical actions that you consider. It's very important when adding non-statin therapies. An important focus of this document was the clinician-patient discussion. As we're talking about with PCSK9 inhibitors, there is a tremendous cost associated with them, rightfully or wrongfully. But in addition, they're injectable therapies. And so really the patient has to be a part of this decision. We also specified the order in which non-statin therapies should be considered, and then emphasized the importance, as did the guidelines, as did the NLA patient-centered recommendations, the importance of ongoing monitoring. So just quickly, I'm going to go through each of the 4 benefit groups. These are patients with stable clinical ASCVD without comorbidities. This is without diabetes, without an acute coronary syndrome. Note that in these patients, the LDL thresholds less than 50% LDL reduction, and may consider an LDL cholesterol greater than 100 for the addition of a non-statin therapy. And these stable patients, it was recommended that ezetimibe be considered first, and then consider PCSK9 inhibitors in addition to or in place of ezetimibe. In patients who had comorbidities with ASCVD, so that's patients with diabetes, recent event, high baseline LDL, cholesterol, uncontrolled risk factors, elevated Lp(a) or CKD. Notice the main difference here is that you may consider an absolute LDL cholesterol of greater than 70 milligrams per deciliter, or a non-HDL cholesterol of greater than 100 in patients with diabetes. Again, recommended ezetimibe first, then may consider a PCSK9 inhibitor in addition to or in place of ezetimibe. In patients with FH or LDL cholesterol greater than 100 with stable clinical ASCVD. Here, notice the main difference, LDL cholesterol greater than 70 for the absolute LDL cholesterol. Or ezetimibe or a PCSK9 may be considered first. So these patients, will you consider what is the additional reduction in LDL cholesterol that may be needed? If it's greater than 18 to 20%, there's no point in starting with ezetimibe. Go straight to the PCSK9 inhibitor. Here, patients with LDL cholesterol greater than 190 without ASCVD. Notice here it's LDL cholesterol greater than 100, less than 50% reduction. Either ezetimibe or the PCSK9 inhibitor may be considered first based on the additional LDL cholesterol reduction that is needed. In patients without clinical ASCVD and diabetes here, this is primary prevention in diabetes. Ezetimibe or a bile acid sequestrant were considered first. Here we recommended bile acid sequestrants were a secondary consideration due to their modest salutary effect on hemoglobin A1C. Currently, the PCSK9 inhibitors are not indicated in primary prevention in diabetics with LDL cholesterol, without an LDL cholesterol greater than 190 milligrams per deciliter. And finally, primary prevention in patients with a 10-year risk greater than or equal to 7.5%. Again, LDL cholesterol greater than 100 and ezetimibe or bile acid sequestrants, PCSK9 inhibitors not indicated in primary prevention. So this is just a summary slide, particularly emphasizing that in patients with LDL cholesterol greater than 190, either ezetimibe or a PCSK9 inhibitor may be considered first. So we've got expert guidance, so what? What difference has it made, really? You know, the payers said to us, we need guidance on how and when and in whom to approve these drugs. We gave them guidance, so what? So one of the issues we've recognized now for the next think tank is that we are having problems with implementation of available guidelines. So we have evidence-based guidelines. We now have expert consensus recommendations. And in spite of that, we are struggling with implementation of therapies. So the third think tank will be held this coming Monday. We will have representatives from payers, from healthcare systems, from actually essentially all of the organizations currently sitting at this table. We will be considering three things. Number one, we will be looking at clinician-related barriers to implementation of guidelines, specifically addressing clinical inertia, failure of clinicians to prescribe evidence-based therapies. We will also focus on patient-related barriers to adherence to evidence-based care. And finally, really the topic of today's discussion, the entire afternoon here will be devoted to systems-related barriers. As you can see, we have documentation required for approval, denials, prior authorizations, really focusing on systems-related barriers. What the output from this think tank will be is up to, this think tank will inform subsequent decisions by the ACC as to how to move forward based on the information we glean from stakeholders. So thank you very much for having the opportunity to discuss the ACC perspective. Thank you.
That was a great talk. Thank you. And thank you again for the opportunity to be here tonight and discuss this issue of PCSK9 inhibitors, what to do, when to do, how to do it, and all those good things. We have some ideas for you from the National Lipid Association, and we have some things that we have done in conjunction with what you've seen from originally in the 2013 ACC-AHA guidelines. first thing that actually happened as we tried to unravel the problems was that we came up with our own Part 1 and Part 2 recommendations. They've been called something like the guideline would be something that would give you the general information, as you spoke to, and our Part 1 and Part 2 were really the how to get it done. And I like that because I think it's important to always have the things that we know are clinically significant brought together by good, solid clinical trial information, but then how do we impart that and get it through to our particular people that we're taking care of? So the National Lipid Association, before the last set of guidelines that were recommended in 2016 by the ACC, came out with Part 1. In Part 1, we didn't have as much to say about PCSK9 inhibitors and how we would suggest and how we would feel that they should be used. But Part 2 were put out a little bit more than a year ago now, and these have been very helpful because what they have done is they've completely looked at situations, much like you have heard, that would be useful for the idea of implementation of classes of medication. Now, these classes of medication, of course, are always going to start with the statin therapies and perhaps even using the ezetimibe with many of our patients. But then, when is it that we may need to have these PCSK9 inhibitors aboard? And our patients today understand that there's a drug out there that's going to be very helpful for them, they hope. And they're anxious to get that drug. But we have to have caution and we have to have clarity before we decide that this is the right thing to do for my patient. Because once you make a decision, it should be a good decision, but then we go through the idea of how do we get it done. I want to call your attention to the first paragraph here when you look at what we said in our Part 2. When we say, until cardiovascular outcome trials are completed with PCSK9 inhibitors, and that's a key piece, because right now we don't have all that. But in the interim, as we move forward and we try to get up and running, we await those. But I don't want to sit around and wait for patients to die when we have some good evidence of good drug. But until we have absolute final decisions from these trials, we should be considering certain things. And here we say, number one, patients with ASCVD who have LDL-C greater than or equal to 100 milligrams per deciliter or non-HDL-C greater than or equal to 130 milligrams per deciliter. And you note that the National Lipid Association still holds on to that non-HDL cholesterol. We do believe that there is a purpose and a need to really take a look at that to let us know how we're doing with our patient population. Now, we should consider some of these things while on maximally tolerated statin or with the use of ezetimibe therapy in that first patient set. And number two, heterozygous FH patients without ASCVD who have LDL-C greater than or equal to 130 milligrams per deciliter and non-HDL cholesterol C greater than or equal to 160 milligrams per deciliter while on maximally tolerated statin plus ezetimibe therapy. And that key to maximally tolerated statin is a subject that comes up all the time, doesn't it? Because who says what is maximally tolerated? How you tolerate, how our patients tolerate is a subjective thing. It is our obligation to make sure that we are trying these things with the patients. We're giving them appropriate education surrounding that. But when they tell us, I can't take, for instance, 40 milligrams of rosuvastatin, once I go beyond 10, I have a problem. I've tried 20, I can't tolerate, I have symptomology. So that maximally tolerated for that patient is 10 milligrams, and we have to accept that. And the good thing about the studies for the PCSK9 inhibitors, they acknowledged that even in some patients, that maximally tolerated statin could be nothing, because indeed there are some people who can't tolerate a statin at any level. But here we see that these heterozygous patients who are not at the appropriate level, while they're on the appropriate drug, should be considered for moving forward to PCSK9 inhibitors. In addition, PCSK9 inhibitors may be considered for selected high-risk patients with ASCVD, for instance, recurrent ASCVD events, who have atherogenic cholesterol levels below the specified values, but above their treatment goals. So it tells you something about the idea. It's about what the patient and what the provider believes is the appropriate level for that particular individual. Such use will be based on clinical judgment, weighing the potential benefits relative to the ASCV event rate and the risk and the cost of therapy. And in the third section, PCSK9 inhibitor may also be considered in selective high or very high-risk patients who meet the definition of statin intolerance as previously defined by the NLA Statin Expert Panel and the discussion I just had with you, and who require substantial additional atherogenic cholesterol lowering despite the use of other lipid-lowering therapies. Such use would be based on clinical judgment, weighing the benefit and the potential risk to the patient, and look at also the cost. And you'll notice that the second and third recommendation there is specific, saying, based on clinical judgment, weighing the potential benefits relative to the ASCVD risk and the risk and the cost involved. Very important information for our considerations. When we move forward, fast forward then to 2016 ACC expert consensus decision pathways on the role of non-statin therapies for LDL cholesterol lowering in the management of atherosclerotic cardiovascular disease risk. Exactly what you just heard Pamela discuss with you. The good thing is that we feel that this came along and added more guidance to the thing that we had with already our NLA recommendations. And our NLA recommendations are recommendations and not guidelines. So we feel comfortable and happy that this set of guidelines has been very well approved and in concert with the goals of the National Lipid Association. So we feel very good about these happenings working together, and we look forward to a whole lot of continuation of good work with these organizations. I want to talk a minute about barriers in the lipid community. What are the barriers for getting these drugs on board for our patient? Cost. The patient thinks so much about cost. It's difficult for the patient who understands that maybe we have a drug that can help them out, but they just can't afford it. Very frustrating. Inconsistent application of maximally tolerated statin requirements. I told you what it is. I told you what a good definition of statin intolerance and what we say it should be. But insurance companies have their own way and measures, and we need to find out and have them have uniformity to what they're talking about as well. Certainly the drug companies have given us an idea that even a zero tolerance is appropriate. That's the max amount that a patient can tolerate. Step therapy requirements, as you heard earlier, they're different for each group. Inconsistent payer application of criteria and audits and pathways. Genetic testing versus clinical diagnosis and who pays for the test, and which test do you order, which one of the 1,000 things are you going to check? And we all know that familial hypercholesterolemia does not require a genetic test in order to be proven to a person to have FH. It is a clinical diagnosis. It sometimes is useful to have these other tests, but it is a clinical diagnosis looking at the body of the person to look for any type of xanthomas, to look at the number of the cholesterol, and most importantly, of course, that family history. Jumping away from that, though, I want to go to the role of the allied health professional. That's certainly my best area of expertise and what I can bring to this organization, because it's critically important when we think about what has to happen to get approval for a patient who needs a PCSK9 inhibitor. My good friends, the doctors here, do really carefully select the patient who they believe should be on the medication. And if they're fortunate in their practice, has someone in their office they can pass that on to. And they can pass this approval getting onto a nurse practitioner, a PA in the office, a nurse in the office, an MA in the office. Therefore, it is critically important that those people in the office have a good handle on exactly what a PCSK9 inhibitor is and exactly why that provider wanted that patient to have it. So when they interface with the insurance company, they are able to have and articulate a good discussion with them. Patient education. The patient gets frustrated when they hear all this. They also get frustrated at the cost. It is up to nursing very often to explain to the patient what FH is. Now, I know our doctors do that. As a nurse practitioner, I've done that. But patients need to hear this more than one time. It's very difficult for them to understand. The staff in the office is in a good position to have that continuing dialogue with the patient. And when they get frustrated with taking 2 and 3 medications on the cost, it's up to the nurses to pull them back in and to help them understand that we can get through this, we can get the right drugs, and you need to understand that this is what you have to have for your disease. Patient follow-up messages and calls. That's the hardest part, and this may even include your secretarial staff in your office. Because when the calls come in first, if a patient's calling, why haven't I heard from the insurance company? It doesn't go to the nurse practitioner, it doesn't go to the physician. That stays at the desk. It's a clerical kind of thing in most offices. And that person, the secretary or the MA, is going to have to be knowledgeable enough to talk with the patient and sometimes even go back and try to find out what is the denial, is there a denial? So the main part of this discussion is that this is a team effort. FH is a family disease, and caring for people is a medical family team that takes care of people to make sure they stay well. I believe strongly that as we move forward with the idea of getting these drugs for our patients, we're going to have to include every person in our team to get in there, to fight, and to do the job that they have to do. Well, it's also about every one of you sitting out here tonight, and we're going to give you a job to do. Because we have been blessed at the NLA to be part of a wonderful survey. At your table, you will find a postcard inviting you and anybody else you want to invite who's a healthcare provider to fill out a survey. This survey is specifically designed to gather your information about what difficulty you may be having with getting your patients onto therapy. What has you been successful with? We really need to know. We will take this data and we will put it all together and we will try to come up with things that will help all the providers across the country to be able to share and to maybe jump over these hurdles a little easier. We have providers that we know in our NLA family that get 100% of the drug. Well, we're picking their brain like a Thanksgiving turkey to find out exactly how you're doing that. There's letters of need that are important. Maybe we'll come up with some letters of need that we can publish that others can use with all the pieces that we find. So please take the time, it's about 15 minutes, to fill out that survey and pass it on to the other people in your practices and other healthcare providers at your organizations. It is a difficult time to get everything we want for our patients, but it's a wonderful time. We have new classes of medications. We have promise of good health for people who needed LDL apheresis for years, and we have an opportunity. What we need most is the patients and the understanding to stay with this and talk about the problems, and that's what we would have you here for you. Thanks tonight.
So as Catherine, a patient with FH and so much more, gets up, please don't leave, though, if you are patients.
I'll be quick.
No, because we really want to hear your story. I just want to mention a commonality that you just heard from Pam from the ACC and from Joyce from the NLA. They go and construct these wonderful, wonderful guidelines or expert opinions that have the best of intentions, and yet the PBMs, the pharmacy benefit managers, pull one sentence out of those statements and use it against the doctors and against the patients, and that is what's going on. So all the hard work that they're doing to create these documents to help the doctors and the patients, I'm sorry, but we see what's happening, and I see your frustration as well. They pick one sentence and use one sentence against you. So, Catherine.
Thank you. I have a favorite quote, listening to everyone here, that I want to start off with. Science tells us what we can do, and guidelines tell us what we should do. Registries tell us what we are doing. The data that I would like to share with you this evening, and I will be brief, I think I only have 4 slides, is primarily from the Cascade FH Registry. which is an active national registry for familial hypercholesterolemia. We now have 30 clinical sites. The top cardiovascular and lipid centers in the United States are participating. We have 9 more sites that are in the process of enrolling. Importantly, part of the Cascade Registry also has been to have a patient portal where we also collect data directly from individuals who have FH, because as you've heard, that's a common theme. That's all I'm going to talk to you about in the last of this presentation part of the panels. But the biggest barrier heretofore for the FH population has been lack of diagnosis. And there's been a dearth of information about the FH population, and we're trying to address that by bringing aggregated data, both from the clinician perspective and directly from the patient perspective, so that we can learn more also about the burden of the disease, their understanding of the disease, and their journey to diagnosis, and hopefully engage them in an ongoing manner to activate them to become more of an educated, participatory part of their medical team. I really believe that in the end, outside of acute care, patients are the last leg of the healthcare system. Every day, I make a decision. I make a risk-benefit analysis based on my understanding of my condition and my understanding of the therapies that sit before me, of whether I will take them or not, whether I'm too busy, how important it is, whether the fact that my legs bother me every evening, that I outweigh that to the fact that I deeply understand how high my cardiovascular risk is. So I'm going to share a little bit of data from the Cascade Registry with you when I figure out how to work this. Thank you. We know, as we've heard now a lot, that the FH population is by definition a high-risk population. We had Kat Davis-Ahmed, our Director of Outreach here at the FH Foundation, myself, several experts, and multiple patients present at the FDA hearing to make this point, that for this high-risk population, as Seth said, time is plaque. We are burdened with a lifelong exposure to elevated LDL levels, and the evidence from the FH population without other comorbidities is that lower is better. And we're all waiting with bated breath for the outcomes data. I mean, nobody, I don't think, in this room who isn't affected by heart disease has their fingers crossed more than us, that the outcomes data will be as good as we all hope. You see here, this data is actually age-matched, the age group of 45 to 64. And in that age group, this is how much more at risk or how much more prevalent heart disease was in this group, either procedures, some clinical form, either in heart attack or an interventional procedure. But interestingly enough, for the FH population, heart disease strikes much sooner than age 45. And we're at a far greater risk if you talk about the FH population in our 20s, our 30s, and our 40s. And this is what we learned from the registry. And again, when you look at this data, please bear in mind, this is data from the who's who. This is Vanderbilt. This is Stanford. This is UPenn. This is Mayo. This is Geisinger. I mean, these are great organizations. People are getting arguably the best care possible, and you still see that the FH population, only about 41% get a 50% lowering. This is actual data of how we're being treated in the US, best case scenario. And 25% an LDL, reach an LDL below 100. We see that this is also a very impacted group of people. 36% of them have been affected who have coronary heart disease and a very young age of onset. This is really one of my favorite slides of all times. The promise of treating FH is actually better diagnosis, screening as early as 2 years old because it is a familial condition, and starting with low-dose statins where we have a lot of data out of Europe that shows that it's extremely effective in dramatically bending the risk curve back to normal, giving people not days, not weeks, not months, not years, but decades more life. But we're, for the most part, in the United States, missing that opportunity. And so what we're faced with is by the time people with FH have even been diagnosed with hyperlipidemia, even clearly understand that they have such elevated cholesterol, they're almost 40. And then, and this is data, these aren't one-off stories. Then it takes almost 7, 8 more years before they are accurately diagnosed as familial hypercholesterolemia patients. And guess what? By then, it's not primary prevention anymore because a lot of them then have established coronary heart disease or it's about to show up. So, you know, I was asked to make a statement about what our position is, the FH Foundation's position on PCSK9 inhibitors. I have to honestly say we are therapeutically agnostic. We will take any safe, efficacious medicine that we can to lower our LDL. And traditionally, we have done that. We have been on the kitchen sink. Most of these patients, the data that you're seeing, they are on combination therapy. This is brand new data. This is not from the Cascade FH registry. This is from a survey that we just sent out to some of our patient population. In less than a week, we had 125 individuals respond. In the last 12 months, this question asked, has your insurance company denied coverage for any of your FH treatments? About 30% said yes. It's interesting, 15% were unaware. But of the 30% who said yes, 72% of those were denied PCSK9 inhibitors. And you see that 60% of those had already had an event or an invasive procedure. And the point that I'm just trying to underline is that this population, which is the population I know intimately, is in need of additional options. And we went to the FDA and we made a case for it, as many others did. And the FDA approved it before the outcomes data and said, yes, there are populations that are at high enough risk, and yes, the evidence that significant LDL lowering will probably lower the risk of cardiovascular disease is significant enough that we're going to make it available now. And now we would like to have the opportunity to have it when appropriate. Just one other word, FH is a very heterogeneous condition. It is genetically heterogeneous. There are over 1,600 known mutations, and it's phenotypically heterogeneous. We are by no stretch of the imagination suggesting that every FH patient requires a PCSK9 inhibitor. Only those who are more severely impacted and or who have had, who already have established heart disease, which we hope to actually avert in more of them. But it is reasonable that we would get the opportunity to have this life-saving therapy, and we're thankful to be able to find solutions with all of you.
Thank you, Catherine. The last statistic was quite impactful. Now, I know a number of patients have come tonight to tell their stories. So if you still are awake enough and want to do that, I think it would be wonderful to hear anybody's stories. Anybody want to get up and come to the mic? Please do.
Hello. How are you doing?
Either way.
I'm a patient advocate with the Global Healthy Living Foundation. Global Healthy Living Foundation accepts grants, charitable contributions from government, individuals, pharmaceutical companies, and private foundations. Good evening, everybody. My name is Roxanne Watson. I live in Nanuet, New York. I got up at 4 o'clock this morning to be here. It's just 25 miles north of Manhattan. In May of 2006, I was working as a retail executive in my dream job in New York City. One afternoon, I was unloading a truck with my associates and felt a twinge in my back. I thought I pulled a muscle, so I went to my office and took an aspirin and sat down for a while before I decided to go home. I returned to work every day for the next 6 weeks. The twinge didn't go away, so I went to my local hospital ER, and after evaluation, was approached by the ER doctor who asked, "How long did you have that muscle pull?" which is what I thought it was. I said about 6 weeks. Why? He looked at me and he said, "Roxanne, you didn't have a muscle pull. You had a heart attack." I was just in shock. How could this be? I was certainly in a little bit of pain, but not that much. I had had a silent heart attack. The cause of organ donation and heart health is now my life. I have volunteered for the past 6 years for Live On New York, formerly known as New York Organ Donor Network, signing up over 8,500 new donors of eyes and livers and everything else. I am UNIS ambassador, and last year I was nominated by Women Heart to be a champion and support network coordinator trained at Mayo Clinic, and I've done almost 100 events in the last year alone. Thank you. My silent heart attack occurred in 2006. I was immediately placed in cardiac outpatient care, receiving all kinds of tests and monitoring, as you guys know. June 2008, I was told to go to Montefiore Medical Center in the Bronx for additional cardiac care. I was admitted to the hospital and over 9 days saw 16 doctors from all disciplines. Finally, I was told by Dr. Shin that she was placing me on the heart transplant waiting list at Stat 2. My heart was deteriorating, and eventually I would need a new one or I would die. I was devastated and terrified. Imagine for a moment hearing this news at age 54. As my doctor predicted, in late 2009, my heart deteriorated fast and my well-being declined dramatically. I was weak and experienced frequent falling episodes and was rapidly losing weight. In April of 2010, at my regular appointment, Dr. Shin told me it was time to actively start looking for a heart. I was 95 pounds. Then, and was placed in CCU for my final weight. The first match came 30 days later, and the heart itself was not acceptable by the team. The second match came a few weeks later, and I was number 2 in the country, and number 1 accepted the heart. I felt like I was drowning, gulping for air at the news, just, devastated, plunging back into abyss while I was waiting for it, to be denied. The third match came a few weeks later and was from a high-risk donor who was a prisoner and possibly had HIV. I was given the choice to accept it, and I decided not to at that point. Finally, 8 days later in CCU, after my 104th day in the hospital in CCU, Michael came. This is my organ donor. I have my organ donor with me. I take him every place I go. He was a United States Coast Guard. He saved 5 lives. He donated everything. I understand that approximately 5 to 10% of the people taking statins experience painful side effects that limit them, and the medication is life-saving. For this portion of the population, these people need help. We can't wait. According to everything that you guys said, I just don't want anybody to ever go through what I did. When I talk to my clinicians about this drug therapy, every single one of them, to a person, talked about the cost and how the insurance companies fight them and won't pay for it. My medical bill, just for the hospital, was over $1 million. That was without the doctors and anything else. If this therapy works, think of the money that can be saved if somebody doesn't go through what I had to go through. It doesn't make any sense to me. And as I sit here and listen, it upsets me. It upsets me to think that this is out there and available, and it possibly could save my life again in the future. So I want you guys to keep fighting. And you said the patient's got to be involved. The patients are involved. I'm involved. Thank you so much.
Thank you.
So it's a very heartfelt presentation, and my hat's off to you and all those involved in your care. Your $1 million hospital bill is quite stunning and not by itself unheard of. I just want to make one point. The pharmaceutical industry is really a target these days for these outrageous drug prices, and in some instances quite well warranted. But in 2014, according to the CDC, the prescription drug costs were only 11% of the healthcare dollar. And hospital care was 40% of the healthcare dollar. And then there's a lot of other things that add up to 100%. And yet, prescription drugs are a very, very easy target, and physicians are even easier. So the insurance companies and the PBMs obviously focus on that. But I really wanted to make that point because it really isn't the drug cost that's driving inflation in the medical field and medical costs. It's hospitalization, and you're a perfect example. $1 million. There are many, many examples of something much less than $1 million. But to prevent one heart attack or one bypass surgery is hugely cost savings. Just like in diabetes, we prevent one visit to the ER for hypoglycemia with our new medications. We pay for the difference between generic and brand name drugs for a whole year because 6 hours in the emergency room is incredibly costly. And we can't prevent hypoglycemia today. And I make this argument every day to the pharmaceutical companies. But I wanted to just share with you that according to the latest government statistics, prescription drugs are responsible for only 11% of the healthcare dollar spent in this country. And that hospitalizations and hospital care is really what's driving our crisis right now, as exemplified by what this gentleman went through. Thank you very much.
Thank you. Thank you.
Good evening. I am
Hi.
Terry Jenkins. I'm a patient of Dr. Baum's. And I just want to get up here and say a little bit of my story on my end. A lot of this has really gone over my head since I'm just the patient here. My aspect, I'm hearing of a lot of cost and issues that you have being as physicians, but as the patient on my end, I'm being denied treatment. I have been paying astronomical fees. That's just a little tip of the iceberg. I try to do the best I can. On my end, I try to follow the rules. I do what they say. But when you try to talk to the insurance companies, you get nowhere. You get denied. And thank goodness I have good people helping me on my end. I just went through with my insurance company, United, denied me treatment that I need every 2 weeks to keep me surviving here. Told me they denied me treatment to go. No reason. And the only thing I can think of is I was at the end of my insurance, and my insurance was paid. It was all for me, free. I can't go. So now I'm denied 4 months. Now I'm back on a new policy. Okay, now I'm back paying again, so my treatments are there. That's just one aspect. There was one aspect, I was offered a medication. I couldn't take it, but we tried it for a while. My insurance company denied me. It was $3,500 a month, my cost. Thank goodness the organization had a foundation to help pay for it. I couldn't afford that. That's just what I'm going through now. Let's not even talk about the other insurance companies I've gone through who denied me treatment for 9 months. I mean, what am I supposed to do? I'm a heart attack waiting to happen. Again, following the rules. You're on the phone with the insurance company. You're crying. You're fighting. You're pleading. Oh, please. And, oh, they'll help you. You call back. They're not there. So this is where I'm at now. What do I do? Where do I go? Who will help me spread my story and saying what we need help here on our end?
Well, and that is what we're doing here, and we appreciate your sharing that with us. But that's exactly what our purpose is to try to gather information and find a solution for this, so you don't have to go through that. And I know the pain that she's gone through, being her physician, and I can tell you, and since you're here, I mean, you know, heart disease at a young age, and you know, deserves every treatment, and has been denied every treatment. So there's just no question about it. It meets every criteria in every guideline or expert opinion paper. So that's what we're here for, though. And you're sharing your voice is going to help us get there. So thank you.
Well, I'm here. Thank you.
I'm a patient of Dr. Baum's. Well, I have been keeping a record for 16 years of my cholesterol. I'm local. I've been seeing different doctors. Never really understood that I have had FH until I met Dr. Baum in January. And I have horrific numbers. I mean, my LDL is 300. My LP(a) is 300. I've seen some great cardiologists, but somehow it never came home to me how serious this is. And we just went through 6 months of denials. And I have Cigna, a private pay policy. And I did just get approval yesterday, oddly enough.
That deserves applause. Yeah.
But they said it's only till December 19th. Why? So I have 3 months, and then we have to go through this all again. But I have to say, Dr. Baum's office has been the only way I could have done it.
Well, thank you for that.
Yeah, I really appreciate that. So I am definitely, wanting to help any way I can. I am just understanding every day now the seriousness. There are some Facebook groups that are great out there that I've joined. So there's a lot of people around the world on that. Anyway, I'm very thankful that you're doing this.
Well, thank you for opening up.
Mm-hmm.
That's brave.
Just to kind of give a little more perspective, the stories that you're hearing tonight and how we're feeling is not unlike what happened when LDL apheresis was started here in our country. It used to take a good 4 months to get an approval for a patient. It took multiple letters. It took everything you could imagine to try to get these treatments started. And when we did, very often we would get 3 months, or we'd have to send a letter every month. And believe it or not, the patient population rose up and really made a lot of noise. And I think that I kind of just kicked them to do it and said, you know, take it to your senator, take it to your people out there, what you need. And sooner or later, people started to be able to be approved for LDL apheresis. But I believe that when we have outcome from PCSK9 inhibitors, and we find that not doing it for our patients is almost criminal, what did Jamie say earlier, absolutely malpractice, I think what's going to happen, patients are going to realize that they need to have it, and they're going to fight. And do you remember when HIV drugs came out and that nobody could get them? They couldn't get manufacturers to make them fast enough. They were costly. They were everything. Why did it change? It was the patient population. So don't forget to tell your patients to push. The other thing that has happened because of patients, years ago, when I was a younger woman, if you wanted to have a mammography test, it was not covered by your insurance. It wasn't considered essential. And women, and the breast cancer groups, really rallied. And they made a difference because now they're covered routinely. So with our groups of people with FH and other things, I believe that we need to make some noise. from the patient population. And all of you who are here, I so appreciate what you've gone through. My husband has FH. I know what you live with, and I know how bad it is. But I also know that you can never give up hope and that there's a lot of people here for you, and we're going to keep pushing to try to make sure these things happen for you.
Thank you.
I have time for one more?
Joe, absolutely.
I'm John Embler. I'm another one of Dr. Baum's patients. I'm being treated for
From my whole
elevated...
patient population.
All three of them.
All three patients.
Yeah, good turnout. We all love Dr. Baum. I'm being treated for elevated LPA. Actually, my LDL and my cholesterol are well below normal, but I've got very, very high LPA. And I've been on apheresis since the beginning of the year. In my case, getting the initial approval for it wasn't that big an issue. Dr. Baum did a great job of pushing that through quickly. But then the insanity started with processing the claims. And it was just one thing after another. I had a patient advocate working with me from Konica, the people that make the apheresis machine. She was great. The people in Dr. Baum's office were great. But I realized that I really needed to be on the phone all the time with the insurance company. And it was just an incredibly surrealistic experience. The lack of coordination between departments, the lack of communication between internal systems. For 6 months, the member services department was showing that all of my premiums were current. The claims and benefits section was showing that all of my premiums were delinquent, and Dr. Baum was not getting paid. I had a ridiculous conversation where I actually conferenced people from 2 of those departments on the phone together, and the guy from member benefit, or the guy from claims, wouldn't take the word from the guy from member benefits that I was current on my premiums. I had canceled checks. It was even in their system. I could see that my premiums were paid. I escalated. It went to the escalations department. They told me it was going to be settled. It wasn't. I filed a complaint with the state. They helped. But what it finally took was I got copied on an email that had the full name and direct phone number of the woman in the escalations department that was handling my case. And I took a deep breath and I called her up and I got nasty with her. I kind of over-embellished connections I have with the media in New York. And I didn't like doing it, but I told her, look, I've got your name, I've got your first name, I've got your last name, I've got your phone number. You're the ones. You are the one that's going to get the phone calls from NBC News and the Today Show. And she got, again, I don't like doing this. But at this point, I was so frustrated. I had to do something. I checked my phone bills, and I'd made in the first 5 months of this year, I'd made over 100 phone calls to the insurance company about this, and had spent upwards of 60 hours on the phone, just with the insurance company, not the calls to the patient advocate or Dr. Baum's office. The lady in the escalations department got very, very upset. I said, look, I'm sorry, I'm not threatening you. I'm just telling you what's going to happen. You are the one that's going to be in the spot. You're the one that's going to have the television cameras at your door. And you're the one that's going to have to explain this ridiculousness. And about a week later, the claims started getting paid. Unfortunately, they didn't get paid for the agreed upon amount. The schedule, the fee schedule, I think just barely covered the apheresis filters. So we went through a whole other round of ridiculousness about getting the insurance company to honor the letter of agreement that they had signed. And then there was a whole other issue with getting reauthorizations. And I'm not, well, maybe I shouldn't share this, but I will anyways. One of my authorizations was coming up. It was the end of 3 months. And they hadn't processed the next one. My patient advocate had access to the Availity system, and I knew to check with her and make sure that the authorization was in there and get the numbers and the effective dates and all that. And in any case, it hadn't been processed. So I called the insurance company, and they said they hadn't gotten the clinical reports. They hadn't been faxed in. I checked with Dr. Baum's office. Of course, they had been faxed in. I asked them to fax them in again. I called back to check to make sure that they had been faxed in and was told they couldn't talk to me about it. They had to talk to your office about it. And I know your ladies certainly spent so many hours on the phone with this. So I called back again and told a white lie. I said it was John Forrest from Dr. Baum's office, kind of keep the arboreal connection going through. And I got through to the review nurse and made sure that she had the faxes in her hand, and I reviewed them with her, and I was able to kind of embellish my own case again and managed to get approval through the end of the year, which surprised me. But this is just the tip of the iceberg, though, is what I went through with this insurance company, and it was hundreds of calls, every single thing that you can think of, and stuff that I couldn't have imagined. They pulled in terms of delaying paying the claims and delaying the authorizations.
Yeah, he did call the insurance commissioner. Yeah, right.
I haven't yet. I haven't gone to the press yet, but I can.
Yeah. Yeah, yeah.
But that seems to be the only thing that resonated with them. Otherwise, otherwise a patient can only get the first name and last initial of anyone they talk to. You can get a reference number of the phone call, but that really doesn't do you too much good if you can't speak to the same person over and over again. The key for me was I was copied on an email that had more information than I was supposed to have, and I could put this woman on the hot seat.
But again, I think what we're hearing from everybody is how remarkably burdensome it is on the patients and how much you guys have to do to accomplish things that should happen automatically. So again, I very much appreciate your standing up here and saying that and telling us.
My blood pressure is going up now. Just,
yeah, right, exactly. Quickly, sit down.
What this gentleman went through was remarkable. If you didn't have coronary disease before, you sure would by the end of your efforts. But I'd like to share with the with the physician group here a strategy that has been somewhat successful over the years with other agents, the new diabetes agents in early days with the potent statins when they were denied. And I was advised to write this kind of a note by an attorney. And it actually worked a few times, and I haven't tried it recently. This is what you say when you are done with your denials and you have nothing more to do. You write a letter and you say, "Dear so-and-so, you have acted in bad faith on behalf of my patient." And bad faith is a legal term that is a little bit scary. And I even put it in italics, bad faith on behalf of my patient. In my professional opinion, it's important you say your professional opinion because you are the professional, person at the other end is not. In my professional opinion, this patient requires a PCSK9 or whatever you're fighting for. Any undue circumstances as a result of this denial will be entirely your responsibility. A short note to that effect. In the past, that's actually worked on a couple of occasions. I have not tried once, and again, I'm going to tell you again how to say it. You have acted in bad faith on behalf of my patient. In my professional opinion, this patient requires this agent. Any harmful result from the absence of this agent, or any way you want to word that, will be entirely your responsibility. And that's it. And see what happens.
I think that's great advice. To that point, just to build on that, sometimes what I do is I'll speak in a peer-to-peer. I'll take the name of the doctor, put the name of the doctor in the chart, tell the doctor that his name is in the chart or her name is in the chart, and that we're going to pierce the corporate veil if and when my patient has an adverse event. I have been hung up upon a couple of times with that, but I have gotten approval. The other thing that I have learned is that the patients have all the power. So with insurance companies, apparently we can appeal decisions and the insurance company doesn't have to keep track of any of these appeals. Once a patient starts the appeal process, then the insurance company keeps track of the appeals. So the patient needs to start it, bring the doctor in, and then everything's tracked. So that's something else that I would add. Yeah. Catherine? No, you look like you want to say something. Does it?
My name is Rachel Keats, and I'm a patient of Dr. Baum. And I just want to say what a wonderful panel this has been this evening, and what you're doing is so very, very important. My story is real quick and very different. I have not had a major event, but I certainly could have had I not met Dr. Baum. I was high risk. My father had a heart attack at 39, had diabetes, and for years and years and years, my numbers were terrible. Not awful, but very high. And I saw red flags with lab work. I'm a psychotherapist, I'm not a doctor, and I'm smart, and I saw that there were flags, and nobody took me seriously. My internist tried statins, which I could not tolerate at all. And I was really hopeless. I had these high flags. I couldn't take statins. I didn't know what to do. And by luck, I saw Dr. Baum's book in a library. I read it, and that was it. And his openness in trying Zetia with me, because all the other doctors said it wouldn't work without a statin, and he was open and listened, and together we brought my numbers back to normal, and I thank you so much. The other thing I want to say, and how one professional helps another, even if you're not in the medical field, I had a patient that came in, a professor, and one of his adult students died that day, just dropped dead of a heart attack in class. And I was going to see Dr. Baum that afternoon, and I told him about it. And he said, I bet it's this hypercholesteremia, which I'd never heard of. And he said, does he have children? And he did. He had 4 children. And he said to have them tested. And sure enough, the 2-year-old, all the way up, they had this genetic disorder. So all of us helping each other to help other people. Wow. It's a wonderful thing. So.
No, thank you. Thank you. Yes, do I have any more patients in the room right now? Yes. Oh, come on up. Come on up. I feel like this is a religious thing.
Good evening, everyone.
Yeah, that's right.
Dr. Baum's patient. Well, I have just a few things to say. Let's start off with, if I don't qualify, who does? I am Dr. Baum's chart that was up on the board. I did have a heart attack at 17. I did have another heart attack at 23. Did have 2 stents placed and ballooned. 2 years later, another heart attack. 2 years after that, another heart attack. I've got 5 arteries bypassed, and I have been denied multiple times. Currently not on my K9 inhibitor. I have my 19-year-old son, and it is hereditary. So again, my question is, if I don't qualify, who does? I'm not a doctor. Obviously, there's a problem. My physician says, I need this. Who's to say he's wrong? An insurance company? So I'll leave it at that. If I don't deserve it, who does?
Boy, well, that is why we're here, and that is why you came, and thank you. I think I'd say we're all tired, and I think we've learned a lot tonight, and I'm so appreciative of everybody here and everybody out there, and I think this was a really meaningful event, the first of other events that will come down the road. So thank you, everybody. Have a very pleasant night, and a good day tomorrow.